Ruth spent her childhood in Malawi and has dedicated more than 20 years to using evidence to improve lives across the African continent. Based in South Africa, she is the director of the University of Johannesburg's Africa Center for Evidence and chairperson of the Africa Evidence Network. Her work includes the production of evidence for decision makers, as well as supporting civil servants to access and make sense of research. The title of her talk is "Do Evidence Networks Make a Difference?" Please welcome her to the podium.
Chairs, honourable members of parliament, public servants, researchers, delegates, friends. Bonjour, Moni, Mulubwanji, Mawia, Benvindo, Siabonga, Molweni, Dumelang, Sanibonani, Karibu, welcome. Before I go on, it is a protocol that I must declare potential conflicts of interest in my presentation. So I must tell you that I run an evidence network, and the network receives funding from a number of sources. But neither I nor members of my team benefit personally from that, except to be able to provide services for our community. So, do evidence networks make a difference? I believe there are two mechanisms that have the power to improve decision-making and reduce poverty and inequality in our continent. One of them is actually relatively new, evidence maps, evidence synthesis and all that. And the other one is as old as the hills, relationships, specifically networks. You're going to learn plenty about evidence synthesis over the next week. In fact, most of you probably already know more about it than I do. So, I'm going to talk about networks, specifically evidence networks. And I'm going to focus on why networks are important and whether evidence networks make a difference. I hope that by the end of this session, you'll share my position that evidence networks provide multiple important connections, including those in the political world that Mr. Manuel will be telling us more about a little later, and the practice world that Dr. Cochrane will also be sharing with us. As chairperson of the Africa Evidence Network, I'll be drawing on experiences within our own network and the many other evidence networks across the continent and further afield. Before I go on, please indulge me just a little and accept my assumption that our shared goal at this conference on using evidence and improving lives is that through the production of high-quality evidence and its use, we want to make a difference to the enormous challenges in our world. Let me say that again. Through the production of high-quality evidence and its use, we want to make a difference to the enormous challenges in the world. My argument is that evidence networks play a key role in our ability to make that difference. Together, we make up many parts of what is becoming known as an evidence ecosystem. Some of us collect data, some of us teach, some of us analyze, some of us write, some of us read, many of us negotiate, others interpret, others make use. We're part of a larger whole. When we work in isolation or in silos, we risk blockages in the smooth running of our ecosystem. When we share information, engage and get to know one another, collaborate, we're forming what you might call evidence networks within the evidence ecosystem. Some networks are sector-specific, such as WHO's health-focused EVIPNet. Some focus on particular health areas, such as ShareNet International, which covers sexual and reproductive health. Others are regional, others focus on particular methodologies. So what is it about networks that make a difference? In our direct experience over the last 5 years, and all that I have read and heard about evidence networks around the world, I've identified 3 things: better understanding, increased capacity, and greater potential for change. I'm going to start by exploring how and why they build better understanding. I understand that the majority of people here today for this summit are researchers, and that most of you are based in or affiliated with universities around the world. What an amazing wealth of knowledge and experience we have in this room. But I want to tell you that if you want to make a difference, you need more than an excellent understanding of your field of research. You even need more than an excellent understanding of systematic review methodology. To make a difference, you need better understanding of who else is in the evidence ecosystem in which you work, what their work is about, their priorities and processes. We also have here members of NGOs, governments, intergovernmental agencies, charities, and more. Practitioners, decision makers, people who we believe sift through our systematic reviews, evidence maps, and other research, and we hope make better decisions as a result. Decision makers, you are often the target of researchers who want you to read their research. But sadly, very little is done to understand the contexts, priorities, or processes in which decision makers work. If evidence-informed decision-making is about bringing evidence and decisions closer together, then maybe we should start with a shared understanding of the various processes, priorities, and potentials in one another's work. Evidence networks enable better understanding, and it's through that better understanding of one another and where we fit in the bigger picture that I believe we can make a difference. Members of the Africa Evidence Network have told us that being part of an evidence network can help bring people together to learn from one another and build a critical mass of scientists, knowledge brokers, and decision makers. I was born and grew up in Malawi, which is one of the poorest countries in the world, and I live and work in South Africa, one of the most unequal countries in the world. I want to make a difference. I cannot do it on my own, however good a researcher I am, even if I'm the most talented of decision makers, the best knowledge broker, the most discerning funder. I need networks. Networks like the Cochrane Africa Network, which is focusing on ensuring that by better understanding the problems faced across the continent, we produce better systematic reviews to meet evidence needs. Networks like WHO's Evidence-Informed Policy Network, EVIPNet, which operates in a number of regions, including Africa, and focuses on forging relationships and building mutual respect to facilitate evidence use. This is all based on shared understanding of evidence and how it can be used. EVIPNet's success stories include enabling greater consideration of evidence in Uganda's National Health Plan, and integration of evidence into Cameroon's malaria prevention plan, shaping alcohol policies in the Republic of Moldova, and reducing perinatal mortality in Brazil. Do evidence networks make a difference? They do, by helping us to better understand each other, and that includes a better understanding of decision makers and decision making, of policy processes, of political and economic histories. Evidence networks enable this greater understanding of all these elements within our ecosystem, even those that we do not yet know about. Next, I'd like to talk about increasing capacity. Now, it's hard for me to admit that I could do with increasing my capacity. I do not know it all. I do not have all the answers. And despite what I tell my husband, I am not always right. But I have learned that I don't only have something to share, I also have much to learn. And that by sticking with people just like me, I limit what I can learn. I spent much of the last 4 years running a wide variety of workshops for decision makers across Southern Africa. The idea was to build the capacity of decision makers to use research evidence. Actually, my team and I learned far more from the public servants that we met than we could ever have imagined. We need evidence networks and the broader relationships that they bring to enable us to learn from one another so that together we make a difference. If you take a few examples of the production and use of evidence that we know are making a difference. In each case, those involved made concerted efforts to learn from one another and to share their capacity. And those relationships began in the form of evidence networks, whether formal or informal. The McMaster model is based on shared learning and respect. By learning from one another, health decision makers and researchers have been able to develop a system that provides the best available evidence in a timely manner for decision making. In this case, the relationships and networks that have been established have enabled both the production of better evidence and its use. Closer to home, we've seen how a willingness for different stakeholders to share their capacity and learn from one another has led to the development of a methodology for evidence mapping, which, while still in its pilot phase, has had a direct impact on policy discussions. This has been based on a co-production model between the National Department for Planning, Monitoring and Evaluation and a number of partners, including my own research centre. Again, through sharing capacity, we've seen the production of more useful evidence. Members of the Africa Evidence Network have told us that they learn from those in other sectors, and that by getting to know each other, now we work together and use evidence to inform policy. And members have told us they learn from others in the same sector but with different levels of experience. They've told us how an individual has become a mentor. He became my mentor and he has helped me. And sometimes, just having others to draw on builds capacity. Network members have told us how it beefs me up. It ties me to something bigger. Sorry. Can someone move on my slide, please? I'm afraid your clicker has stopped working. Thank you. Do evidence networks make a difference? They do, by increasing understanding and by increasing our shared capacity. It's working now. The quotes I've been using come from a survey of our network members. Now, I'm going to be honest with you, it is really hard to capture instances of networks changing the world. Instead, networks seem to make a difference by building greater capacity, greater potential for change. Some of you will have read Duncan Green's book, How Change Happens. In there, he talks about what triggers change. If you read his book, you will sadly have to accept that change does not follow from the swift publication of your research paper, however high profile the journal and however long the words you use. Instead, change is often triggered by a catastrophe, a change in leadership, a financial windfall or a recession, a public outcry, a hurricane, a drought. What Duncan identifies as key is to be ready for when these triggers occur. We have found that evidence networks have the potential to build this state of readiness. Understanding evidence ecosystems, understanding where we fit, who else is in the system, what they do, what they need, and how decisions are made, all of that means that we can be ready. This can include being ready for when a funding call comes in, having a partner in mind, a collaborator that you trust, someone whose advice you can ask, a community you can call on. It can include being ready when a need for evidence arises, so decision makers know who to call. It can mean having a network so that together we can act when we see opportunities for change. Evidence networks provide potential, readiness, and in so doing, they are the foundations that one day can lead to change. People tell us, I knew who to call. We trusted each other, so when the call came, we could act. Do evidence networks make a difference? They do. Networks share information, increasing our collective understanding. Networks enable sharing of capacity, and networks build potential, readiness for change. The Africa Evidence Network started in 2012 with 23 disparate and very different people from across Africa making a commitment to stay in touch, to share information, and to learn from one another. Since then, we've grown to over 1,200 people from nearly 40 countries. 26% of our members are members of governments across Africa. We share information about the evidence ecosystems around the continent, what's happening where, workshops, publications, seminars, webinars, training, funding, and more. We liaise with other evidence networks. We have a website, blogs, newsletters. We tweet, and we share, and we meet. If you want to know more about us and the many other networks that are here today, come to our stands in the exhibition hall and meet some of us. And if you'd like to get to know more about the African evidence community, come to Evidence 2018 in Pretoria this time next year. To close, those of you who fly out from Johannesburg through OR Tambo Airport will see in the international departure area a mural. And it says, if you want to go fast, go alone. If you want to go far, go together. Do evidence networks make a difference? You, me, the summit, I believe we are the answer. Thank you.
Thank Thanks, Ruth, for a really thoughtful presentation. We will hold any comments and questions till after all three presenters have completed their input. So it gives me great pleasure to now introduce Patrick Okwin, who is our next speaker. Patrick is a Cameroonian medical doctor and a health economist who's passionate about improving global health outcomes. He's conducted research in many areas. He's been involved in public health research and in systematic reviews. And Patrick works in health development as well as governance at public health institutions in Cameroon. And we look forward to Patrick's talk around how we can get to best current evidence in clinical practice in Africa. Let us welcome Patrick to the podium.
Good morning, chairs. Good morning, Honorable Minister. Good morning, colleagues. I'm Patrick Okwin, and I work as a medical doctor in Cameroon. I also do part-time research with the Center for Development of Best Practices in Health. I'm also the Cochrane Obrey Sheham Evidence-Based Healthcare Leadership Fellow for 2017. A Joanna Briggs Clinical Fellow, and also lead for Guidelines International Network for Africa Community. So today I will be talking about how we can get best current evidence into clinical practice in Africa. For my disclosure, I have no actual or potential conflict of interest in relation to this presentation. My objectives for today would be to share with you experiences on how primary healthcare in low-middle income countries can implement evidence in clinical practice through global collaborations and local action, and also to highlight some barriers and some coping strategies, as well as perspectives for improvement. So I would like to start with the evidence ecosystem again, as the previous speaker had mentioned. And I would like to say it's similar to what we have in nature. We have primary research that builds into evidence synthesis, which builds into guidelines. So each one of these depends on the other, and it goes in a circle. So the idea of collaboration is going to look into this, and this is where we will see the importance of the networks and how primary healthcare could actually draw from existing networks of evidence synthesis. Now, key to my talk, or key to my experiences, and what many of my colleagues have experienced in Africa, is the role of the Cochrane collaboration. And I would specifically like to start with the Indaba 2013, which was a meeting of leaders. It was an African colloquium of Cochrane, which was a meeting of leaders. Indaba in Zulu means a congregation of leaders. And we were just talking before the presentation what message we got during this meeting when Jimmy mentioned that now the Indaba is over, go and be leaders. So in these networks, we can see that there is the Cochrane collaboration. Then we have Cochrane Africa, which has just recently been launched. But also we have Cochrane South Africa, which has been in action for quite a while, working with the MRC. And then we also have the CDBPS and Cochrane Nigeria, which are both running Cochrane systematic reviews within the African continent. Then we also have the Center for Evidence-Based Healthcare in Stellenbosch. Then we have Africa Evidence Network, which is where Ruth has just given us some talks about. And then we have the Learning Initiatives for Experienced Authors, sponsored by Cochrane. And the picture there, that's the picture of Obrey Sheham. And we have an award, an annual award given by Cochrane for outstanding authors or physicians for leadership for evidence-based care in Africa. So just to give you a picture of what we feel like sometimes when we are in primary care, we say Jawanda. Jawanda is is a Cameroonian statement. Cameroon is a mix of English and French. So sometimes when we speak, you don't know if we are speaking French or English. So when we say je wonder, we simply mean I wonder. There are questions you ask yourself when you are in practice. So sometimes I ask myself, why do we still give hepatitis B vaccines to kids born to HBV positive mothers in Africa at 6 weeks? Or why is it that the government still dish out without tests for typhoid when clinicians actually disregard the results? So these are the questions I ask myself when I'm in practice, and this is where I need the networks to draw from. So I'll start by looking at some examples. Now, this is how I feel when I sit at my consultation. What do I do when I have a mother there who is positive for hepatitis B, and I have to wait 6 weeks to give the vaccine or to protect the child from contracting hepatitis B? And I say it would be better we start looking at working from context rather than working out of context and then attempting to bring this into context. And this is what we hope we can draw from our networks, that we can push into them to tell them exactly what are our needs, and then they would be able to help out. Now, in primary healthcare, there are still some barriers that you sitting at the clinic you would face. For example, there is still some paucity of relevant research evidence and synthesis. As we saw, despite all the networks, a lot has been done, but there are still some challenges. Sometimes the evidence is not available in a usable form, in a digestible form. Sometimes it's not relevant to our context. And then sometimes access to the evidence, the journals and the databases. It's not so easy to get full text papers of systematic reviews and primary research. Cochrane has done a great job to let systematic reviews to be available for those of us in sub-Saharan Africa. But sometimes the primary papers that you may need may not be available for free. I've spent the last about 4 weeks at the Center for Evidence-Based Healthcare in Stellenbosch, and I would say that it's amazing when I just click on a paper and I'm able to get the full text. It's such a feeling that you will never be able to get when you are in clinical practice in sub-Saharan Africa, the kind of place where I am. Now, sometimes the access is free, like what we have with Cochrane, but most clinicians are not aware, so we need to get the message rolling out there. Then also the capacity to use the evidence, the primary data, the synthesized data, or the guidelines. I usually tell systematic reviews authors that the beauty of a systematic review is in its complexity. But it's that complexity that may probably turn off the clinician because he doesn't understand where to go in to look for what. So maybe we need to think about how do we get them to go to the conclusions in simple language, something like this. Then I will go through a number of examples that I've experienced in my practice. The first one will be the rapid recommendations with the British Medical Journal Rapid Recs, which we used for prevention of HIV and during the perinatal period. Then clinical audits at district hospitals, which I used with the Joanna Briggs model. And then evidence-based task forces at hospital, which is an approach we are beginning to implement in Cameroon, which is a form of pushing to the doctors to make them develop PICOs and then give this back to the researchers to develop evidence summaries. And the guideline toolkit, which is an interesting tool I discovered while I was at my stay at the center in Stellenbosch. Now, to start with my first example, I was moved by a new paper, the PROMISE trial, and the fact that we had at our disposal a lot of free antiretroviral treatment for preventing mother-to-child transmission. And I was asking myself, how can I give the best treatment to the mothers and at a good cost and be able to cover certain comorbidities that I thought was a problem in my practice? So I first looked at the evidence ecosystem. That's why I got the primary study. Then I got connected with the BMJ Rapid Recommendations, and we got into motion for developing some rapid recommendations. Now, the video for how to do a rapid recommendation, because this is something which every clinician could actually engage in if they have a question that they would like to answer, is found, you can actually find it on YouTube if you search how we make a rapid recommendation. Now, the participation in a rapid recommendation, it's a collaborative process whereby you have clinicians, you have patients from everywhere coming together and attempting to develop a PICO, a question, a research question to search evidence, and then also to develop the outcomes in particular. Here you can see that on the side there is, here there is scoring. So every participant in the collaboration would score what they think is most important to them. For example, I could score that cure is what I want to see most in my patients. But if we have patients on board, the patients could say, cure is not what I'm looking for. What I'm looking for is that I can take this medicine and I do not have a birth defect with my child. I could also be saying that I want to see a treatment that would be cheaper for my patients because my patients are not able to pay so high for treatment. So this is how the process for participation, for developing the questions, goes about. So in this case, we developed a rapid recommendation for prevention of mother-to-child transmission or reducing transmission during the perinatal period. And as a clinician from Cameroon, my concerns were cost effectiveness. How feasible is a particular technology for my patient in terms of cost? And I was also looking at comorbidity issues. In certain areas in Cameroon, you have hepatitis B infections up to about 40%. And I think we are losing an opportunity there from testing women during the antenatal clinic period. This is because we already have a program set up for preventing HIV, which could actually synergize with the one for preventing hepatitis B. But unfortunately, the vaccine comes very late at 6 weeks, which actually is a problem because certain drugs that are effective for HIV could also be used as prevention for mother-to-child for hepatitis B. So in this picture, you could see that I was asking questions around feasibility and meaningfulness with respect to comorbidity. You can also see that there was another comment from a clinician in Kenya who was contributing. So this is the way the collaboration goes about. So this rapid recommendation was actually published in British Medical Journal 1 day ago. That was yesterday. So you can see that we have some opportunities here. The option B+, which is what is recommended by the Cameroon National PMTCT program, actually recommends that we start with tenofovir, lamivudine, and efavirenz. At the end of our recommendations, we had a slightly different picture. We were suggesting here that we use zidovudine and lamivudine-based antiretroviral regimens over one that includes tenofovir and emtricitabine. This is because those options are actually cheaper and they were more likely to cause, less likely to cause side effects in the mother. Then we also asked questions around setting. For example, what's more feasible in low-middle income settings? And we also looked at it with respect to the hepatitis B transmissions. And then also we looked around risk of resistance because, for example, a woman who has hepatitis B, actually, who takes zidovudine may also have a risk of developing resistance in the long run. So this is why it may be important to separate the two groups, understanding that we have a high chance of comorbidity in this community. Now, the set of slides that will follow shows you a multi-layer, because what happens with the rapid recommendations is that we try to bring recommendations to clinicians anytime, anywhere, and on any device. This means that on their mobile phones, they could actually have access to recommendations. Thank you very much. So this is a screenshot of what you will have on your phone when you open the Rapid Recommendation. So as you can see, we have used grade. You can play, you can play around this and see various different options, and it can direct you on exactly what to do when you have a patient in front of you. So this is the first multi-layer recommendation and decision aid, which tells us that in women living with HIV who are pregnant or may become pregnant, we suggest a zidovudine and lamivudine-based antiretroviral regimen over one that includes tenofovir or emtricitabine. And the good thing with this recommendation is that these medications are all available locally. So the patient doesn't have to pay anything extra. Now, this is another interface that we may have. For example, if we want to discuss with our patients what aspects of the treatment would you like to discuss next. For example, maybe the patient would want to discuss about stillbirth or birth defects or HIV transmission or hepatitis B transmission. So you would click on any of these options and it will take you to the recommendation. Here we see in simple terms exactly what this is among 1,000 patients like you on average with tenofovir-based ART. We give the options here. We will have a more detailed presentation on this topic tomorrow at 2 p.m. and in meeting room 1.43. So if you are interested, you could come along. Then the second example is the clinical audit in primary healthcare, which the setting could be the setting for this particular one was district health service. We will also be giving a more detailed presentation of this later today in the ballroom east. So this clinical audit in primary healthcare used the Joanna Briggs model, and this was a collaboration between JBI using evidence from Cochrane systematic reviews and WHO guidelines. I initiated this practice in clinical care, or this clinical audit in primary care in Cameroon. And it was supported by the Joanna Briggs Institute through training, softwares, and mentorship. It's been submitted for publication also in an implementation science community. This is the Joanna Briggs Systematic Review and Evidence Implementation Reports database. And it was implemented at District Health Service. Now, the clinical audit was based on evidence from Cochrane reviews and WHO guidelines, and it sought to promote evidence-based practice of test, treat, and track. And this was based on 5 evidence-based criteria for treating uncomplicated malaria in children less than 5 years of age. In the end, this was the results we had. Based on the criteria, we wanted to ensure that the doctors are testing with a rapid diagnostic test or microscopy before they start treatment. And also that all cases of uncomplicated malaria were treated on outpatient basis and with oral medication. And as you can see, the orange lines indicate the practice before the clinical audits. So after the first baseline clinical audits, we go on to talk with the clinicians and to give them details on evidence why they should practice certain best practices. Then after 6 months, we come back and check. So we give, it's kind of audits and then give them feedback. Then we come back and we check, and you can see that there is some great improvement. For certain criteria, we're not able to measure because the technology was not available for practice locally. So we find out that we have some graphics here that we can use to approach policymakers and also talk with the patients to show them that practice is improving because we used evidence. Now, let's look a bit at, we've seen the networks, we've also seen some barriers, and we've seen some examples. So now, I'm trying to build up here some opportunities for synergy. Now, we've seen that there are existing networks. There are also rapid, we also have access to rapid review recommendations and rapid reviews. There are also evidence summaries. There are also contextualized guidelines that could feed into clinical audits and feedback to develop evidence-based practice criteria. There are also opportunities that we could build on in Africa. This includes like using the lay health workers, because lots of task shifting is happening, and lots of practices can be moved because there are not so many doctors or clinicians. So some of this is being moved to lay health workers. There's also the Kigali Declaration, which is pushing forward an agenda for evidence-based practice. Then there's also performance-based financing, which is becoming very popular across Africa, but which is still struggling to find its way as to how can we bring in evidence into practice. So this availability of rapid recommendations and clinical audits, existing networks, could really build on these options that we have in green to develop evidence-based practice in Africa. So here we have the other examples I mentioned. We will not be going into this in details. Now I would like us to revisit our question. Can we get best current evidence into practice in Africa? I believe, yes, we can do this. This, to happen, it will be important for us to operationalize these good ideas and many more that are out there. We must be ready to get engaged and bring on board all stakeholders and all networks. We must be able to identify barriers and tackle them. We must be able to exploit existing opportunities, especially within context. Also, we need to build around the WHO, the World Health Organization, because they have a good track record for influencing governments and ministries of health to do the right thing. My take-home message will be that we have opportunities to network and synergize to implement evidence-based clinical guidance in Africa using locally available technology, and I think we should go for it. Thank you, merci, and miyaka.
Thank you very much, Patrick. That was a very interesting presentation. I now have the pleasure of introducing the last speaker in this plenary session, Mr. Trevor Manuel. Mr. Manuel served in the South African government as Minister of Finance from 1996 to 2009. He was first appointed to this position by Mr. Nelson Mandela and retained in this office by two subsequent presidents. From 2009 to 2014, he served as Minister in the Presidency, during which time he chaired the National Planning Commission, which oversaw the drafting of South Africa's first National Development Plan. Mr. Manuel has held senior leadership positions within numerous international bodies, including the United Nations, World Bank, the IMF, G20, the African Development Bank, and the Southern African Development Community. He has been widely recognized for his accomplishments in social and economic development and upliftment through receiving numerous prestigious awards and 8 honorary doctorates from universities in South Africa, as well as McMaster University in Canada. If I were to summarize, I would say that Mr. Manuel is firstly an esteemed South African citizen. He's also a seasoned politician with a heart for people, a dying breed, I suspect. He's also a global leader in terms of social and economic development. And on a more personal note, we also know him to be someone with a great sense of humor. So Trevor, it's an honor to welcome you to the podium.
Thank you very much, Jimmy. Good morning to all of you. Molwen, and welcome. This is going to be tough. I'm of course the outsider here. I'm not involved in evidence-based research, and unlike most of you, I'm not a clinician. I've tried many things. The honorary doctorates don't allow me to practice, which is rather unfortunate. But thank you, Ruth and Patrick. I think that your presentations helped educate me immensely this morning, so I'm greatly appreciative for the fact that we were able to reorder the presentations and help my learning. And Taryn, thanks to you as well. I've had some difficulties in trying to work through how to approach a topic at hand. And the reason is that now that I'm outside of government, I begin to understand that there are real difficulties because one looks at the world from a very different vantage point. And I think that there's a divergence of where I am from the intricacies of policy making and the use of evidence. And I think it's not a bad insight to start with, because I don't think I'm alone in this view. What's very important for me, and I think as part of this sort of outsider's view, outsider looking in, is to understand that the detail of evidence-based research, especially in health, can't be divorced from evidence-based research in social policy more broadly, or general policy, and certainly it cannot be divorced from the great leadership challenges that the world face right now. And part of this is that we live at a rather difficult point in world history. When one looks at some of the trends, and let me cite some examples here, I think of the Philippines and I think of President Rodrigo Duterte. He said about saying that the one thing that he wants to do is to rid the Philippines of drug users. And for a while, journalists were following the body count and they've stopped counting. But about a month ago, President Duterte, who said that his intention is to deal with 3 million people by extrajudicial killings. There were 32 extrajudicial killings by police in Manila on one day. And he commended the police and said, if we had 32 every day, this would be a very easy matter. Now, for those involved outside of health, evidence is fundamentally important in law. And when an individual doesn't even have the prospect of evidence presented in a court of law, led by a leader of a country, then the prospects of dealing with evidence-based policy making in healthcare or any other social policy, I would submit, is virtually non-existent. The other end of the globe, of course, we see similar attitudes emanating from the White House, where I'd like to put it to you that Donald Trump abhors the use of any evidence. And this is so clear from his pronouncements on all manner of issues, from economic policy to healthcare provisioning to peace to whatever, but nowhere more strongly than in his denial of the science that informs climate change. And in the spite of what they're living through now, 10 days ago there was Hurricane Harvey, and this week there was Irma, and just a few weeks ago there were huge wildfires in the west of the country. The stoic resistance to any science that informs climate change remains very much intact. And this resulted in a very interesting standoff between a former secretary for the Environmental Protection Agency in the US, Christine Todd Whitman, who served while George W. Bush was president. And she wrote this piece in the New York Times just last week, where she identifies herself as Scott Pruitt is a Republican who shares the same values about the free market and so on, and then goes on to say, but decisions must be based on reliable science. And he has around him, Scott Pruitt has around him what he calls the red team, and she says, the red team begins with his politically preferred conclusion that climate change is not a problem and will seek evidence to justify that position. And for this conference, very importantly, she says, that's the opposite of how science works. True science follows the evidence. The critical test of peer review and replication ensure that consensus is sound, unquote. It's very important to understand that these issues are going to find resonance not just in healthcare or social policy, but in all of policy. And part of the battle is to ensure that we have approaches that are as consistent as they can be. Now, having picked on the Philippines and the United States, I should say something about South Africa in this regard as well, because just last week, President Zuma was addressing an audience just outside of Cape Town here, and he spoke about the fact that the ANC had lost the elections in this province. And he ascribed the loss to witchcraft and voting ghosts. Now we have an instance where, in the face of elections having been supervised independently and declared free and fair by all parties, including the party that he leads, the ANC, the response is so ridiculous to suggest that the results are a consequence of witchcraft. If that's the approach taken to tangible evidence of votes counted semi-publicly, what hopes do we have for leadership and evidence-based policy making? I sketch this context to provide some flavor of the challenges that exist both globally and on the continent, but I'm sure many of you know far, far more about these issues than I do. There are many of us who'd want to tell you wonderful stories about how great and universal the application of evidence-based policy making is across the African continent, and how it's maturing over time. The truth is rather different, and part of the truth that confronts us as Africans is that progressively policy room was taken away by the way in which governments are funded on the African continent. It's a combination of donor aid, and the donors frequently decide what governments can do, or it's borrowings from multilateral organizations that for many generations have come with structural adjustment. And the only thing that happens with structural adjustment is that there's one set of determinants, and those are economic. Policy room is taken away and policy capacity is removed, and so it's tended to create a hand-to-mouth existence in the policy space across the African continent. We need to understand this, because I think it still presents as one of the major threats to the way in which we begin a process of continuous change across the continent. And the evidence of this, I think, is clear. I mean, you can look at the health conditions and the frequent pandemic outbreaks, whether you're talking of Ebola or Congo fever, waterborne diseases, diseases like malaria that remain in the main unchallenged, HIV and AIDS. But similarly, if one looks at the big challenges that remain unresolved in respect of dealing with the quality of life through organized and ordered urbanization, where Governments allow this to happen without evidence or evidence-based planning, including the absence of networked services, water sanitation, electrification, broadband, and so on. We could equally focus on repeated failures in education and the positive responses that we have seen to the MDGs, for instance, with education, especially of girl children up to primary school level. But all of that speaks to initiatives enforced from the outside and the absence of clear, informed policy making that provides a better basis for sustainability. I want to make the point that this reality exists and it's not for want of trying. The movement amongst African statisticians has grown in leaps and bounds, and many who I have encountered across the African continent I describe as brave and bold, and those aren't adjectives normally associated with statisticians, but there you go. But the poor quality of maths and science teaching in many African countries will continue to retard the development of the large cadre of statistics professionals that we require. Notwithstanding, the battle for such production and the building of institutions continues apace. The fact that most African countries have conducted censuses in the UN 2000 round is a major achievement. The battle to have outputs even as elementary as census results utilized in the process of policy making remains, I think, one of the big challenges. I will concede that the current time, just like it is in the world, is not a particularly good time for leadership across the African continent. You know, there've been in the past 2 decades amazing leaders. I think of the group who gathered to agree on the African peer review mechanism and the content of that initiative, and it exists in name now. But it's not a particularly good time. But we have some things going for us, and one of those, I think, is 30 months ago, African leaders at the AU summit agreed on a vision for Africa called Agenda 2063. Now, planners would know that the horizons are very long, but it is important that we get the orientation right, that we all point ourselves in the same direction, and that we then begin to work on more manageable and measurable and empirically supported and evidence-rich data over the shorter period, 5 years, 10 years, and so on. The provisos are, of course, that leadership remains committed, focused, and remains strong and strongly committed to Vision 2063. Many of you may be aware that South Africa adopted its first long-term plan 5 years ago. I'm very worried on the evidence because Professor Chikte here said 6 years ago. It's 5. And while the horizon of South Africa 2030 is much closer than Africa 2063, in presenting these two, I think that we are saying that it's possible for the continent to draw on some of the experiences we have in order to deal with some of the nitty-gritty issues around Vision 2063. The process that we undertook, I think, presents a series of learning opportunities in the drafting, the consultation, and the implementation. I should add a footnote here, that having had the privilege to chair the first 5 years of the process, I don't want to be either too proprietary or precious about the National Development Plan. I don't want to be deprecatory of the current efforts either. I want to be clear about those. I know that the presenters here are meant to declare interest, and this is my declaration. I thought, however, that some of this experience shared with you might give you a sense of how we used evidence for planning during this process in South Africa. At great risk, and having said unkind things earlier, President Zuma established the NPC, comprising one minister and 25 individuals drawn from outside of government to form this National Planning Commission and to take a critical view of government's efforts and then to develop proposals for medium-term transformation. Bear in mind that this would be a risky enterprise in any government when the Commission had carte blanche and nobody checked the political pedigree of any of the commissioners. The approach that we took was that we needed to understand the terrain before we could plot the journey. So the first output was a diagnostic report. This audience would not be surprised by that and wouldn't be surprised by the fact that this is a result of the medics who beat us into submission to ensure that we started with the diagnostic report. And we were able to publish this about a year after the establishment of the NPC. We set as a big frame we wanted the elimination of poverty, provided we could agree on the poverty line, and the significant reduction in inequality in the country, so that Ruth doesn't say these things about how highly unequal we are. But based on available research and data, we identified 9 challenges that we thought would be key to overcoming these issues. These are too few people work, that the quality of school education for black people is pretty poor, that infrastructure is poorly located, inadequate and poorly maintained, that spatial divides hobble inclusive development, that the economy is unsustainably resource intensive, that the public health system cannot meet demand or sustain quality, that public services are uneven and often of poor quality, corruption levels are high, and finally that South Africa remains a highly divided society. We took this diagnostic report, discussed it very widely. We had town halls, we even had an online discussion with just over 10,000 South Africans under the age of 35 in a concentrated 48-hour period. We sat in radio stations, we met faith groups, we got agreement from all political parties in this country. And arising from this consultation, it was very important that we were able to do this, to demonstrate that we were listening. We needed to add 3 big challenges: social protection, community safety, and the rural economy. We're then able to take these and begin working on what was a plan around implementable proposals in each of these areas. But we reconstructed the frame so that we could focus on the cross-cutting rationale for programmatic implementation. And then we introduced what we called the elements of a decent standard of living. Things like employment, healthcare, safety and security, education and skills, transport, housing, water, sanitation, electricity, nutrition, a clean environment, and recreation and leisure. And we thought that if we have this in place, that we should measure our general performance against this. It goes without saying that income through employment and social security is an essential element, but insufficient without attention to those broad spectrum of elements. But it also counteracts the notion that governments can make announcements about a few disparate projects and say we're implementing a national development plan. The plan is actually about a decent standard of living for everybody. And you know, given the structure of the Commission and limited time frames, it meant that we could focus on the overarching reach of the plan and also begin working then with implementing agencies, including government departments, of which the NPC is not one. The plan also spoke to the need for active citizenry to attain the outcomes. So I want to cite some of the examples of the details raised, because I think it may enrich the way in which you look at the issues of evidence here. I do, however, want to say that in order to get to the plan, it wasn't the ideas that sat in our heads, but very importantly, the reality of the prevailing conditions that we were starting from. So in addition to the wide consultations with the public in all its forms, we also had intense consultations with research and data institutions, both in academic and professional sphere, as well as those funded by government such as Statistics South Africa. The proposals we then made were supported by the prevailing evidence rather than simply wishful thinking. So I'd like to use some examples to illustrate how, even across this plan, there are different approaches that we were able to take. Chapter 4 deals with economic infrastructure, and one part of the chapter deals with the energy sector. It starts with the awful reality of South Africa's coal dependency. It introduces the risk of carbon emissions. It covers matters relating to energy regulators, to policy making, to legislation, to energy access, to matters such as tariffs. It's linked to industry and transportation. It introduces options for an energy mix, including the substantive introduction of gas and clean coal technology. And it then goes into a fairly touchy subject of nuclear power. And the plan says, and I quote, according to the integrated resource plan, more nuclear energy plants will need to be commissioned from 2023 and 2024. Although nuclear power does provide a low-carbon baseload alternative, South Africa needs a thorough investigation on the implications of nuclear energy, including its costs, financing options, institutional arrangements, safety, environmental costs and benefits, localization and employment opportunities, uranium enrichment and fuel fabrication possibilities. An in-depth investigation into the financial viability of nuclear energy is thus vital, unquote. So we're not sort of anti-nuclear. We're saying that there are series, we set the hurdles that must be cleared by government in order to get to that point. My concern right now is that there's less rigor about discharging that particular obligation by both government departments and Parliament. So if you want these things, then produce the evidence. Produce the evidence that would support the decision-making was the approach that we certainly took on energy and a range of other ideas in the National Development Plan. The 10th chapter deals with promoting health. And the diagnostic report had drawn attention to the harsh reality that while private healthcare is available to about 16% of the population, the funding levels for public and private healthcare were roughly equal. The steep gradient of a quality differential was self-evident. The approach was thus, unlike in other areas of work, that it's primarily a resourcing matter. And the chapeau of the chapter in the plan reads, health is not just a medical issue. The social determinants of health need to be addressed, including promoting healthy behaviors and lifestyles. A major goal is to reduce the disease burden to manageable levels. Human capacity is key. Managers, doctors, nurses, and community health workers need to be appropriately trained and managed, produced in adequate numbers, and deployed where they are needed. The national health system as a whole needs to be strengthened by improving governance and eliminating infrastructure backlogs. The National Health Insurance Scheme needs to be implemented in phases, complemented by a reduction in the relative costs of private medical care and supported by better human capacity in the systems in the public health sector, unquote. The approach is thus very different from that taken in the energy sector, in the same plan. Here the burden of responsibility is for systemic transformation as a precursor to improved public health. Part of the challenge in South Africa is that the delivery of primary and secondary healthcare is a provincial responsibility, with National Ministry and Department of Health having very limited powers. The distribution of healthcare professionals is also exceedingly uneven. Healthcare professionals like to be, firstly in Cape Town, then in Johannesburg. Beyond that, it just drops off very radically. Just recently it was reported that the entire public health system in the province of KwaZulu-Natal, a province that is home to just under 11 million people, is left with just 2 oncologists and equipment that is entirely decrepit. We find that too many provincial health departments have employed excess non-medical staff consuming personnel budgets incorrectly. The evidence push has to be focused on better budgeting, better planning, and infrastructure improvements for health provision in general, and to close the quality gap between private and public care in particular. You know, as these challenges in health have actually consumed the intellectual energy of people in healthcare, the issues that used to matter to us. I mean, I'm saying, I'm from outside the sector, but I could recite the Alma Ata Declaration. The importance of constructing a system of public health care that's very different from where we've been was once on the agenda, but I think it's just lost in the translation of too many problems that have arisen. The 9th chapter deals with improvements to education, training, and innovation. It's important because unless we deal with evidence and improving lives, as your theme suggests, and apply this to education, we're not going to make much progress in this country. The approaches and the recommendations, again, different from both the energy sector and the health sector, is a full spectrum approach that deals with recommendations throughout people's lives. It actually starts with nutritional support for pregnant moms and infants. Goes through early childhood development, universal, compulsory, the schooling system, the school management systems, the upgrading of teacher skills, school nutrition, access to learner support materials. It deals with some rather unpopular issues as well, including the use of external assessments with remedial action for teachers. We've conducted annual national assessments in the past, we've ended them now, but we've done them for the purpose of conducting annual national assessments, not to introduce remedial action into the educated core in our country. So it runs through all of those things. It makes significant proposals for change to the school management system. And then it deals with the tertiary and vocational education system and also the university system. In the eyes of many, the implementation of these proposals, I think, would ensure that we have a fulcrum for leveraging change in society. The scale of these changes requires an honest assessment and management of planning, but moreover, each proposal requires the development of evidence to construct benchmarks for progress. The only thing that we talk about in South Africa is grade 12 passes, and that's a pretty incompetent metric for trying to improve the education system anywhere. The entire approach must then be synthesized to measure progress in education in order for the gap between rich and poor to be narrowed. In the absence of evidence and measurement, we are left with the ongoing disputes about improvement, and the lack of progress remains most marked in the lives of the poor. As a last example, I'd like to deal with another fundamental issue, human settlements. As with all of the other examples, education, health, even energy access issues, the legacy of apartheid remains an obstacle. In the case of human settlements, it's of course forced removals. Those of you unfamiliar to Cape Town would have come in on the freeway and seen that vast area of land unoccupied and say, how long has this place looked like this in a city anywhere in the world? It's part of the problem of Group Areas Act and forced removals in our history. Now, in many ways, the Group Areas Act still exists as it was. For poor people, they live in the townships designated for race groups. And so the challenge of restoration and reconciliation are at the very heart of this change. But what we can't do is take corrective action that would seek to move families once again, this time for the purpose of integration and improved circumstance. It would be resisted because it would conjure up all of the memories of forced removals under apartheid. It matters, therefore, what happens in new settlements to change the aggregate outcomes. I want to share a specific example from an area not too far from where we are right now, and an area I observed quite closely when I flew in this morning. Just south of the Cape Town International Airport is a large piece of land that has been in private hands for a long time. In the past 18 months, this land was occupied by several families, and the estimates from aerial photographs now suggest that about 60,000 people live there. This matter was recently as last week. It's not as recent as the publication yesterday in the British Medical Journal, but last week in the court, cut me some slack. There was an application from the three groups of individuals who owned the land and who now found this land occupied, and they wanted the city of Cape Town to compensate them for the loss of their land. The court granted the application based exclusively on matters of land use, despite the fact that the entire settlement is in what they describe as the airport noise corridor. The judgment has to be understood against the backdrop of all of the elements of a decent standard of living. The area, housing 60,000 or so people, has no health facilities, no schools, no communal areas, no roads, no reticulated water or sanitation, and no arrangements for refuse removal. The lives of the people who've settled there in desperation can only go downhill from there. In fact, it's quite impossible for the local authorities to go into the area, demolish the shacks in order to reticulate services, and then reconstruct the shacks on top of the now reticulated services. The alternative, which is to build permanent brick houses instead, would create unbelievable chaos to existing waiting lists. What decision should the court have taken on this matter last week, and informed by what evidence? Since there ought to be sufficient evidence to focus on how to sustainably improve lives. I've attempted to provide you with a sense of the depth of the challenges being faced in South Africa, even in the face of the overarching availability of evidence to do planning. There's no excuse, however. It also raises the question on why South Africa has found it so difficult to deal with the ongoing challenges of poverty and inequality. After all, we have world-class data on income distribution informed by 3 competent censuses since democracy, as well as numerous community surveys conducted with professionalism that places South Africa in the global upper tier of official statistics. There are also longitudinal panel studies such as the National Income Dynamics Study, which assesses the impact of a lack of income on families over time. More recently, the research project on employment and income distribution and inclusive growth has been able to measure the distribution of wealth using data from the South African Revenue Service. The picture they provide is worrying, with about 95% of the wealth concentrated among 10% of the population. Income inequality is wide but less pronounced because social grants and a redistributive tax system dent it somewhat. Perhaps we need to look at the issue of inequality again and again. It's not only about income and wealth. As the author Tony Judd put it, inequality is not just unattractive in itself. It clearly corresponds to pathological social problems we cannot address unless we attend to their underlying causes. There's a reason why infant mortality, life expectancy, criminality, the prison population, mental illness, unemployment, obesity, malnutrition, teenage pregnancy, illegal drug use, economic insecurity, personal indebtedness, and anxiety are so much more marked, unquote. So we need to reframe the public discourse to find remedies for the damage inequality does to our social fabric, at the same time as tackling the causes. Measurement should be the order of the day for fact-based policy making, development implementation and measurement of progress. How far have we come in implementing development programs, in making a difference, in dealing with the major challenges facing our country such as health, unemployment, poverty and inequality? How do we know? Are we succeeding? Are the broad objectives and goals attained? Are the interventions benefiting those who are meant to benefit? What evidence do we have for Africa to measure our inroads into the African Agenda 2063, which clearly states a developmental trajectory which leaves no one behind? The economist Esther Duflo, who is attached to the JPEL at MIT, recently said, and I quote, "In technology we spend so much time experimenting, fine-tuning, and getting the absolute cheapest way to do something. So why aren't we doing that with social policy?" Unquote. Is this not the one end of the challenge? Whilst evidence exists from evaluative research, it does not seem to find a landing pad in government. At the other end, and perhaps there's also a cynical view expressed by John Maynard Keynes, who said, "There is nothing a government hates more than to be well informed, for it makes the process of arriving at decisions much more complicated and difficult." Unquote. I, of course, want to apologize because so many of the examples I've used are from economists, but forgive me for that. In the realm of the academy, there will remain many disagreements about matters such as evidence. I've recently tripped over a paper by a researcher based at the Indian Health Policy Center, Devaki Nambia, who argues that evidence-based policymaking in health systems is a myth. She lifts from a definition, and it just shows how uninformed I am about what happens in this town. She lifts from the definition of the Health Systems Research Symposium meeting held here in Cape Town in 2013. And she says, "A situation where high-quality, locally applicable, synthesized research evidence using the best available data informs, in the time available, action by elected officials, public servants, managers, including NGOs, health workers and patients and citizens, also donors, media, and other intermediaries, including researchers, systematically and transparently in agenda setting, policy development, or implementation," unquote. That's a definition that arose from this 2013 meeting here, and then she kind of slams it. But she says that she only has to slam it because there isn't much action beyond the conference and its very detailed definition. I don't know much about these things, Jimmy. You have to resolve these things for me. She does say that the realization comes as a trickle, not a flood. And I expect that there will be a range of different opinions from within the research community. But the biggest battles, I think, that we have to confront relate to matters such as, firstly, the need to continue to advance the methodology and place of evidence in the policy-making community. The biggest counter to be confronted is the comfort of uninformed opinions and ideology in governments. The second huge battle remains leaders who never allow the facts to get in the way of a good story. They surround themselves with people who tell them what they want to hear and not what they need to hear. You see, the issue of leadership is so profoundly important. In the short life of democracy in this country, in its early stage when Nelson Mandela was president and Nkosazana Dlamini Zuma was Minister of Health and I was a smoker, the campaign against public smoking was quick and fierce and in a very short space of time resolved. You look at the present milieu, And there's probably more evidence supporting some action against sugar. But this country can't get a decision. Just last week, Parliament again deferred that decision for another 8 months. And it's just about taxing excessive sugar use. And the differences in a very short space of time are so stark. But these are the issues that actually matter. So as I ponder these questions, I'm reminded, and I want to quote somebody who, to the best of my knowledge, is not an economist, Queen Elizabeth II, who arrived at the London School of Economics to open a building effectively in the wake of the financial crisis. And there were these gathered great and the good, the smart economists attached to the LSE. And the Queen said to them of the crisis, quote, "Why did nobody notice?" unquote. So in the battle to ensure that appropriate decisions are taken, it's important for the body of researchers of evidence for policy to retort, and I quote myself here, "We are the canaries in the coal mine, our business is to notice and to advise," unquote. I plead for your unrelenting commitment at this. Thank you very much.
So thank you very much, Mr. Manuel, for your inspiring talk and for really setting the scene for many things that we need to consider as we go into the summit over the next 4 days. We have now come to the end of this first plenary within the Global Evidence Summit. I would just ask you to give all our speakers another round of applause.